Okay. Hi, everyone. I think we'll start now. So it is my pleasure to present Dr. Amy Janis. She's a senior investigator at the National Institute of Drug Abuse, directing its Cognitive and Pharmacological Neuroimaging Unit. And she was formerly an associate professor in psychiatry at Harvard Medical School, McLean Hospital for 15 years, researching substance use in neuroimaging. And while she's been a recipient of multiple awards for research and mentoring, and she's currently serves as a president of the College of Problems of Drug Dependence. And I want to thank her for her effort for coming. As I mentioned, she has some health issues, and I appreciate that she made an effort to come and be with us today. Thank you. Thank you, Amy.
Thank you for inviting me. As was mentioned, I got sick right before I was supposed to get on the plane. I'm mostly better, but if I start coughing, I apologize. I just need a second to catch my breath. And I'm very sorry I couldn't be there in person. I was really looking forward to seeing all of you, getting a chance to chat with everyone. And I just really want to thank Eduardo and the whole committee for inviting me to speak. And with that, I want to talk about some of the work that my lab has been doing using neuroimaging to understand substance use with a focus on nicotine dependence. And a lot of what I'm going to talk about touches on different elements that we've been talking about through the whole symposium. But another goal of what I'm going to talk about is to give some concrete examples of how we can use fMRI in different ways to understand substance use disorders. So to get started, again, something we already talked about, smoking rates are at an all-time low. And this is largely due to education, that people know that smoking is having a negative health impact relative to what people were doing back in the 1960s. But despite the fact that smoking has come down significantly, smoking and nicotine use is still a major cause of preventable death, at least in the United States, meaning that smoking and nicotine use is still having a negative impact on public health. And unlike other drugs of abuse, we actually have treatments for nicotine dependence. And so the fact that nicotine use and smoking is still having a very negative impact on public health, despite the availability of smoking cessation aids, means we need to start looking at this in a slightly different way. And one of the reasons why I think it's so difficult to treat nicotine dependence as well as other substance use disorders is because there's so many different factors that play a role in why someone is using a drug of abuse. We know that there are individual differences in how people respond to a bunch of different factors that are risks for using and continuing to use a drug. These individual responses can come from how people are responding to the pharmacological effects of nicotine itself, to how they respond to cues in their environment that can motivate feelings of craving and lead to relapse. We know that biological factors play a role, things like sex differences. And we also know that there are other things like different comorbid psychiatric disorders that play a role in nicotine dependence and other substance use disorders. And focusing on these different factors and individual responses to these factors is a main focus of my lab, and trying to understand how these different elements individually and collectively can come together to make someone more or less vulnerable for continuing to use. And so as we move through the talk, I'm going to go and, as I mentioned, give an overview on the ways we've studied this from different perspectives using different neuroimaging techniques. So first, we're going to start off with some of our older data looking at brain reactivity to smoking cues. As Hamed mentioned earlier this week, smoking cue reactivity is one of the primary ways we've been studying substance use disorder in the brain, and this is something that we've been doing for over 15 years. And this will also provide a basis to understand why it is we're looking at specific brain regions when we come to other ways we can look at the brain. These other ways involved other methods, such as resting state methods, and I'll talk about two of them. One is a static connectivity approach, which is probably the one that most of you have heard about the most and has been what others have talked about during this whole symposium. And that's a static connectivity approach, which allows us to determine how the brain is organized, whereas newer methods are going to allow us to determine how the brain is functioning at rest. And collectively, these will allow us to determine how the brain is kind of more inherently functioning when we're not kind of manipulating anything with a task. And from there, We'll expand our discussion into nicotine dependence by also talking about mental health, both by talking about transdiagnostic factors, which are elements of mental health that cut across different psychiatric disorders. And then we'll also be talking about categorical diagnoses as well, and how these things might impact nicotine dependence, but the neurobiology of nicotine dependence more specifically. So as I mentioned, our lab focuses on smoking cue reactivity quite a bit. Not only is this near and dear to my heart because we've been studying it for such a long time, but it translates well into preclinical models. And we know that coming into contact with a cue that reminds someone of using a drug of abuse can motivate relapse. It can evoke feelings of craving and can get people to shift their behavior away from doing what they know is healthy and can lead them to continued use. We also know that a lot of our frontline therapies, such as nicotine replacement therapy, while it's good at some things, it's good at reducing withdrawal-related craving, it's not terribly good at reducing cue-induced craving, meaning that cue reactivity is a relatively untreated risk vulnerability factor, at least when we're looking at the perspective of pharmacotherapies. Other things like what Colleen was talking about and getting into cue reactivity with TMS might be other ways that we can target this. But we've been really focused on trying to understand what the neurobiological basis is of cue reactivity, and can we identify individual variability in how people respond to smoking cues. And the way we do this is we have people smoke one of their own cigarettes about an hour before they undergo fMRI scanning. This is to pharmacologically time lock when they last smoked relative to when we're going to measure brain activation to smoking versus neutral cues. And this technique allows us to then identify where in the brain we get more activation to smoking versus neutral stimuli. And that's what I'm showing you here on these 3 orthogonal slices of the human brain. These hot colors represent where there's more activation to smoking versus neutral cues. And we see this pattern in parts of the brain like the medial prefrontal cortex and the posterior cingulate cortex, which are both primary nodes of the default mode network, which is a core neurocognitive network that plays a role in internally directed cognition. So things like evoked emotion, episodic memory, anything that's really driving your attention internally to these internal states having to do with memory and evoked emotion. Another brain region that is commonly active to smoking cues is the insula. And this is something that Yihang Yang brought up earlier in our panel. This brain region is highly implicated in nicotine dependence, and it plays a role in interoception. So how you're feeling, whether you're feeling a little bit tired, a little hungry, a little bit like craving a cigarette. And it, along with the dorsal anterior cingulate cortex, is a primary node of the salience network, which plays a role in integrating those salient internal states of how you're feeling with salient external information. Say, maybe there's a smoking cue out there, in order to drive a response. And collectively, this pattern of brain activation is something that we see over and over and over again. And it actually overlaps with a meta-analysis that we currently have under review, where 51 studies of substance use cue reactivity were evaluated. So overall, this pattern of brain activation is pretty reproducible, and we believe that it is something that has some ground truth when it comes to cue reactivity. And we also know that activation of parts of these circuits, parts of the default mode network and the salience network, are related to clinical outcome. For instance, we did some work a while ago showing that individuals who have heightened insula activation to smoking cues, even before they tried to quit smoking with the aid of nicotine replacement therapy, those who have this heightened insula activation are the ones who are more likely to relapse when the treatment is not really geared to cue reactivity. So it's sort of saying, well, if your treatment isn't helping with cue reactivity, having this heightened cue response is a risk factor to lead to relapse. And this pattern of heightened insula activation to smoking cues being related to relapse is something that we replicated in an independent sample, and it fits with the work of others who've shown similar things. For instance, others have shown that having heightened insula activation to cocaine-related cues is associated with poor treatment outcome. And collectively, this fits with a broad literature of the insula playing a critical role in nicotine dependence, We know that damaging the insula can reduce smoking in humans, and damaging it in rodent models can also reduce nicotine seeking. And we also know that from TMS research that targeting the insula seems to have some relationship with better treatment outcome. So not only has the insula been shown to be related to key reactivity and treatment outcome, but we know that affecting the function of the insula has an impact on whether people are smoking or not. So kind of pulling this all together, the main point of me telling you all of these things is to point out that the salience network and the default mode network are very important when it comes to nicotine dependence. Both of these networks reliably react to smoking cues, and activation of parts of these networks is associated with treatment outcome. But not only that, individual variance is really important because it's not necessarily going to be a one-size-fits-all thing. It's not necessary that every single person is going to have this heightened cue reactivity. Maybe some of them are. And so one thing that we really think in my group is that we need to understand those individual differences to understand when we need to use treatments that are guided to more address cue reactivity versus when we might need something to address something else. But since we now have an idea that key reactivity and activation of the default mode network and salience network are very important, we wanted to further understand the role of these networks in nicotine dependence. And we decided to then move a bit away from looking at task activation and instead look at how the brain was functioning at rest in terms of these networks function. So we did this two ways. One is our static connectivity, and the other is dynamic. So I'm going to take a little bit to kind of give examples of how we use both of these different techniques. So resting state analyses with functional connectivity is probably what you've mostly heard about, which is where we're going to take the bold fMRI signal from one part of the brain and another part of the brain. And we just ask, how synchronous are these bold signals? The more correlated they are, the more we think that they're functionally connected, that they're working together because their fMRI signal is going up and down together. And we can use this information then to understand how the brain is functionally organized at rest, which might help us then understand how this variance in functional organization might impact how the brain is then going to function when we give a task, and how that might lead to someone responding to cues in a certain way. Excuse me. And that's exactly what Dr. Laura Murray in my lab did, where we conducted a study of 86 individuals who use nicotine daily. 67 of them use combustible cigarettes. And after the pandemic, we had to switch and also look at folks who vaped, because in the United States, vaping is on the rise. So 19 people had been using a vape device. And what we did was we measured craving before any scanning took place. We then did our resting state fMRI analysis, and we did a cue reactivity task. This is a nicotine task, so it's not necessarily smoking, but the cues are matched to whether you're a combustible cigarette using individual or if you vape. And then we measured craving again. And from those pre and post craving measures, we're able to calculate cue-induced craving, which is just the subtraction of the amount of craving you have after the cues versus before. So we can just see how much those cues were kind of pushing up your craving level. And this analysis or this design allows us to look at a couple things. One, it allows us to determine whether there are differences between those who smoke and vape, and then whether our resting state connectivity as well as cue reactivity help us understand the subjective response to cues. So now we're trying to pull in more information, not just look at how the brain is acting during the cue reactivity task, but understand how its functional organization is also playing a role. So to first address the question of whether there are differences between those who smoke and vape, we have two groups: people who smoke in blue, people who vape in red. And when we look at this subjective report of cue-induced craving, what we see is that craving goes up after you're exposed to smoking cues or vaping cues. No differences between the groups. This was very good, I guess, because this is what we would expect. We would expect that cues associated with nicotine would evoke feelings of craving. And here we're showing that that's true both whether you vape or you smoke. And when we look at brain activation to smoking cues, first we focused on regions of interest that we know play a large role in nicotine dependence, specifically the anterior insula. And once again, we see the same pattern of having higher insula activation for our nicotine stimuli relative to neutral for both the folks who vape and those who smoke. So no differences between the groups. Same pattern when we look at regions of the default mode network. Lots of activation during the nicotine stimuli, not as much during the neutral stimuli. And when we do a whole brain voxel level analysis, we see that the patterns of activation, whether you're smoking or vaping, are exactly the same for when it comes to cue reactivity, really indicating that the processes that happen for smoking are true for vaping. Now, as we were talking about before, vaping can be seen as a harm reduction technique because people are not getting the combustible effects of smoking, so they're potentially reducing their exposure to carcinogens. However, this is showing that the neurobiological processes associated with cue reactivity that we know lock in smoking use are the same as what we're seeing for those who vape. So this is going to allow us to translate what we know about smoking to vaping, and it's also going to allow us to collapse across our groups, at least in this study, because the neurobiological processes are the same. And what we wanted to do next, though, is determine whether our resting state functional connectivity relates to how much cue-induced craving people have. Is there something in the way that the brain is organized that puts someone at greater risk for experiencing more craving? And what we did was we focused on connectivity between the salience network, which includes the dorsal anterior cingulate cortex and the insula, and parts of the default mode network, which include posterior cingulate cortex and medial prefrontal cortex. So we looked at all of these connections, and after correcting for multiple comparisons, we saw that the relevant connections were between the posterior cingulate cortex and the dorsal anterior cingulate cortex. Specifically, in both of our groups, those folks who had stronger connections between these two parts of the default mode network and salience network were more likely to experience a greater level of craving after they were exposed to smoking cues, which to me is pretty cool because here are two networks that we know play a large role in nicotine dependence. And what we're showing is that stronger connections between them, even when somebody isn't doing anything, even when they haven't been exposed to the cues yet, is placing them at relatively higher risk to experience larger levels of craving. But we also wanted to see, well, what about how the brain is functioning? Because we also have our cue reactivity task where we did fMRI as well. And so what we wanted to know was whether that rise in cue-induced craving was also related to how the brain was functioning during this nicotine cue task. And what we saw was that greater levels of cue-induced craving is actually linked with a deactivation to nicotine cues in parts of the prefrontal brain. And this is something that fits with everything that we've been talking about, or a lot of the studies that we've been talking about during the symposium and a lot of the TMS work, because what we saw was that greater levels of craving were associated with less cue-induced activation to the dorsolateral prefrontal cortex, the frontal pole, and the superior frontal gyrus. Again, fitting with this idea that if you have more engagement of these prefrontal brain regions, you're going to have less craving. Because here we're showing the other side of that coin, less engagement of these brain regions, more craving. And as we talked about earlier, stimulation of parts of the prefrontal cortex have an effect of being able to reduce cue-induced craving. So this pattern of brain activation makes sense and it fits with the literature and it fits with what we know are actionable targets for things like TMS. But now we want to pull things together into a broader framework of understanding risk vulnerability, because we have all of these different puzzle pieces, where specifically what we know is that if you have stronger connectivity between parts of the default mode network and salience network, well, you're more likely to experience a greater rise in cue-induced craving. So how your brain is organized at rest places you at more risk for experiencing cue-induced craving, as does a lack of activation of parts of the prefrontal cortex, such as the superior frontal gyrus. But kind of rounding this story out, what we also found was that this stronger connectivity at rest places one at more risk for having less prefrontal activation to those cues. So now we're creating this more linear story of the way your brain is functionally organized at rest. Those circuits can be different, placing one at more risk for having the brain less reactive to smoking cues and parts of the brain that we know should be regulating craving. And then that collectively leads to a greater rise in cue-induced craving. So our indirect effect here was also significant because what we're showing is that these things are all interrelated. It is not just how the brain is organized or how the brain is activating, but there's an interaction of these things that can impact cue-induced craving. So when we are talking about these analyses, what we found collectively is that there are no differences, at least for the measures we looked at, between those who smoke or vape, which I mentioned will allow us to collapse our data, will allow us to apply what we know to smoking to vaping. And it also suggests that the processes that support continued smoking likely also support continued vaping as well. So while vaping might in fact reduce risk in some way, it's still not healthy, it's still not necessarily good. It's still creating cues that are going to motivate continued use. And we've also created a story talking about how resting state organization of the brain can influence how the brain is then activated, which can then influence how someone is subjectively feeling, which collectively can motivate relapse. And so this really begs the question of where along this pathway do we target treatment? And we've talked about some of that throughout this entire symposium, because we can target treatment in different ways for different needs. And it's possible that if we target this pathway with different interventions in different ways, you might facilitate a better effect, meaning that you could potentially go in with TMS and target prefrontal brain regions, which can have effect on cue-induced craving. But you can also do things like CBT to talk about cue-induced craving and how you're responding to those cues, while also kind of acknowledging and recognizing that you might be more vulnerable to have this higher cue reactivity because of the way your brain is functionally organized. And so you're kind of in this risk place even before you come into contact with a smoking cue, meaning that it just might be a little bit more challenging for certain types of behavioral interventions to help because of the way your brain is functionally organized and how you are reacting to those cues. But one question we had was, well, this is great and makes sense. It fits with what we know, but does the connectivity between our two networks, the default mode network and salience network, relate to real world measures of craving? And this is another study that Dr. Laura Murray did, this time looking at 49 nicotine dependent adults, all of them who are smoking. We'd have no vaping cohort in this. In this study, we scanned people prior to them making a quit attempt. And this is the study that I had mentioned before, where we're going to go and have people quit smoking with the aid of an electronic cigarette that has nothing in it, as well as nicotine replacement therapy. So it's very similar to just NRT, but it has this behavioral crutch as well. But we were really interested in more knowing if the way the brain is organized at rest before you even try to quit smoking, if that relates to how you're experiencing craving during that 2-week cessation period. And here we just asked about the functional connectivity between our default mode network and salience network, and showed that more anti-correlations, meaning that these networks aren't working now in opposition from one another. Well, the more they work in opposition from one another, the less amount of craving individuals are going to experience during smoking cessation. So this is the opposite side of the coin from our laboratory study, which showed that more connectivity between the default mode network and salience network was linked with craving. Here we're showing that more opposition between these networks is associated with less craving during treatment. So collectively, this study, or both of these studies, is really indicating that connectivity between the salience network and default mode network relates to clinical variables of craving, both in the laboratory as well as during a smoking cessation attempt. So we're providing more ground truth for how these networks are functioning, being related to something clinically relevant and nicotine dependence. But what we've been talking about are static measures of connectivity. our resting state scans can on average last between 6 minutes to about 30 minutes, which means there's a lot of data in there that we're reducing down to one number. We're really asking just how correlated over that 6 or 30-minute resting state scan our bold signals are. We're not getting any information on what the brain is doing, which is where dynamic measures can come in. And so I want to take a couple minutes first to talk about methods of dynamic resting state analyses, and then provide some evidence to show you that these measures can be influenced pharmacologically, meaning that looking at how the brain is dynamically functioning could be a target for treatment, and then provide some data linking dynamic measures with nicotine dependence and other clinical variables. So we also do dynamic measures at rest. So again, we're looking at how the brain is inherently functioning. We're not doing any sort of task. And what we've done is an analysis in collaboration with Dr. Rosie Kaiser and Dr. Blaise Frederick, which is a coactivation pattern analysis, which works very differently than the functional connectivity measures that we talked about earlier. So how this works is first you parcelate the brain. You break it up into anatomical or functional pieces. And then you ask at each and every time point of your fMRI scan, well, what's the direction of the bold signal within each of these regions? And so for the data that I'm going to present, we have a 30-minute resting state scan, and each time point lasts 720 milliseconds. This means we have a lot of time points where we can ask the question of, well, what is the bold signal doing in this part of the brain, and this part of the brain, and this part of the brain? And from this information, we're able to calculate these patterns of activation of which parts of the brain are kind of going up together and which are going down together. And then we can ask, well, how long is the brain residing in these states? How many times do you enter into these states? How long do you stay there? So now we can get some information about how the brain is functioning, not just how different parts of the brain are communicating with one another. And we did this in 462 healthy individuals from the Human Connectome Project. And we looked at two 30-minute independent resting state scan days, which allows us to then determine if the temporal patterns we're seeing are reproducible. So what this measure gets you is it allows you to identify patterns that the brain can reside in our resting state scan. This picture is very pretty, it's very colorful, but not very informative unless we kind of dig into it a little bit more. And so I want to draw your attention to state number 3. And I've put some circles around the medial prefrontal cortex and the posterior cingulate cortex. And hopefully those brain regions kind of make sense because those are two primary nodes of the default mode network. So state number 3 is our default mode network state. And if I were to walk you through each and every one of these 8 states, what you'd see is that they spatially overlap with well-known core neurocognitive networks having to do with salience and emotion and reward and attention. And what this is saying is that this method is identifying states that the brain can be in that spatially overlap with things that we would expect based on the literature. So this to us kind of makes sense, but of course we were really interested in the temporal properties of these states. How long at rest does the brain kind of enter into one of these states and stay there? And that's what we're showing here, where we've calculated the total time in seconds that our group of 462 individuals are spending in each of these 8 states during our 2 resting state scans. The take-home message here is those bars look really, really similar because they are. Our resting state scan day 1 is shown in blue. Our resting state scan day number 2 is shown in orange. And what you can see is that the amount of time the brain is residing in each one of these 8 states is very reproducible across the days. So collectively, this is saying that this method can define states that the brain goes in that overlap with core neurocognitive networks, and that the temporal properties of these networks or these states the brain can be in are highly reproducible, at least when we're looking at a large sample of healthy individuals. But this gives us the confidence in this method and allows us to then expand on it to understand what this method can really give us. And one of the questions we had was, well, is there a pharmacological impact on the temporal dynamic properties of these dynamic states. And this was done, led by Justine Hill, who is a research postback in my lab, as well with Cole Cornprey, who is an instructor at Harvard Medical School. We did this in 59 healthy individuals who were scanned 3 times using a randomized double-blind placebo-controlled design. So people got placebo, they got the dopamine and norepinephrine transporter inhibitor, methylphenidate, which leads to an increase in both of these neurotransmitters. And then they got 2 milligrams of haloperidol, which is a dopamine due to D3 antagonist. And we assessed the temporal patterns of all of our 8 networks. And what we were really looking for was how the temporal patterns of these networks changed. And what we plotted here was the total time in seconds that people were spending in these states, looking at methylphenidate in blue, placebo in pink, and haloperidol in orange. And what we see here is that methylphenidate reduces the amount of time spent in the frontal parietal network, whereas it increases the amount of time spent in the default mode network and increases the amount of time in the dorsal attention network. And so many of you probably know that methylphenidate is a treatment for ADHD, which improves attention. And so I want to take a minute to explain why we think this makes sense by talking about work done by Nathan Sprang, who looked at the frontal parietal network, the default mode network, and the dorsal attention network in the context of different goal-directed attentional tasks. Specifically, what their lab did was gave people an autobiographical planning task or a visual spatial planning task. Autobiographical planning is an internally directed attention task. You need to kind of pay attention to internal cognitive states, whereas the visual spatial task requires you to pay attention to external stimuli in order to do the task. And what they showed was the default mode network activates for the internal attention, deactivates for external attention, whereas the dorsal attention network shows the opposite, and the frontal parietal network activates for both types of attention because it's thought that the frontal parietal network is going to play a role in guiding attention to meet task demands, meaning that when you need to engage the DMN or the DAN, the frontal parietal network is going to help kind of pull into that state. And what we showed with our resting state temporal dynamics is that methylphenidate at rest increases the amount of time in the default mode network and the dorsal attention network. So basically what's happening here is the brain is almost primed to respond to attentional demands, no matter what the flavor is, no matter if it's internal or external. Your brain is in a state that is associated with both internal and external attention, whereas it decreased the amount of time in the frontal parietal network, potentially because we're doing this at rest. There is really no need to cognitively pull things into different states, or it could also be interpreted as, well, if your brain is sort of more naturalistically going into the default mode network or dorsal attention network, your brain is more primed to meet those demands without the need of cognitive effort like the frontal parietal network would provide in order to move into those different states, really suggesting that methylphenidate increases time spent in networks involved in attention, which might allow attentional demands to be met more easily. And so what we've been able to show thus far with these methods is that dynamic properties of the brain are reproducible within a large group of healthy individuals, and that dynamics are impacted by pharmacology, suggesting that this method holds promise as a treatment target, because we were able to show that methylphenidate had a very specific effect on network dynamic properties. And we did not see that same effect due to haloperidol. So we have this idea that different drugs are going to impact different networks in specific ways. And potentially, if we know how network dynamics are linked with cognitive and clinical elements, we might be able to use interventions like pharmacology, talk therapy, TMS, in order to modulate those dynamic states in order to have better outcome. But the question is, well, are these dynamics actually linked to clinical elements? And this is where our talk will shift a little bit into bringing in this idea of comorbid psychiatric disorders, because we know that there's a strong link between nicotine dependence and mental health issues. Before, we were talking about how smoking rates are now at an all-time low, but what you might not know is that about 40% of those who smoke do have some form of serious psychological distress. And if we were to look at any diagnostic category of a mental health issue, a large proportion of them are also smoking. So this is really suggesting that those who smoke are going to have a higher likelihood of having a mental health issue, and those with a mental health issue are going to be more at risk for developing nicotine dependence. So there is some need to understand where and why we have these links so we can come up with treatments that are meeting the need of the folks who also have some sort of comorbid psychiatric issue. But to get into this, we wanted to pull in our temporal dynamic measures as well. And our first question was really getting into this idea of linking childhood trauma with substance use disorder. And this was work led by a postdoc in my lab, Annika Kwam. And she was interested in this because we know that early childhood negative experiences are associated very strongly with substance use disorders, and nicotine dependence is no exception to that. But what we wanted to know was, well, is there some other transdiagnostic element that might explain these strong links? And to get into that, we focused on alexithymia, which is defined as impaired awareness of one's internal state, resulting in difficulty experiencing, identifying, and expressing emotions. The reason why we focused on this is because alexithymia is high in those who've experienced negative childhood experiences. It's high across psychiatric disorders, so it's one of those transdiagnostic elements, and it's also high in nicotine dependence. But not only that, alexithymia, in theory, fits with the functioning of our two networks of interest, the default mode network and salience network, because we know those brain regions are playing a role in sort of salient processing and awareness of internal states. So it's plausible that this transdiagnostic factor might also be integrated somehow with the functioning of our network. And so for this study, we also paid attention to the amount of time people spent in a certain brain state known as the frontoinsular default mode network, which represents the co-activation of both of our networks at the same time. So this is not really looking at how these brain networks are talking to one another, but it's looking at when these networks kind of activate at the same time. So what we did here, excuse me, is we had 102 individuals who did smoke and 102 individuals who did not. We measured their amount of childhood trauma as well as the amount of alexithymia they experienced. And then everyone underwent a 60-minute resting state scan, which allowed us to look at the temporal dynamic properties of our frontoinsular default mode network. And the first thing we did here was we just asked a very simple question of, do our groups differ? And what we found is, yeah, they do differ. And they differ in a way that makes sense. Specifically, our nicotine-dependent group, shown in blue, they spend more time in this frontoinsular default mode network than do our healthy controls. And this makes sense. It fits with the literature because these two networks are very strongly implicated in nicotine dependence. And as we talked about before, the fact that they work together more strongly at rest is related to more craving. So it makes sense that when we look at a group of people who do and do not use nicotine, that it's those who use nicotine who are going to be spending more time in this state at rest. So collectively, this is just another piece of evidence looking at the brain in a different way, showing that these networks are in fact important when we're thinking about nicotine dependence. But we wanted to take this a little bit further and ask how all of these features and transdiagnostic measures also play a role. And so I want to show you the results of a moderated mediation looking at these elements in those who smoke. So what we saw was that more childhood trauma is associated with more alexithymia. This makes sense. It fits with the literature. We would expect this. What we also saw was that more alexithymia is associated with less time in our frontoinsular default mode network. And I'll explain that in a minute, but I just want to round out this slide first by saying that there was not a direct relationship between trauma and total time spent in our frontoinsular default mode network, but that relationship was influenced by alexithymia. So it's really trauma-related alexithymia that is associated with our time spent in our frontoinsular default mode network, but only for those who use nicotine. These associations were found in our nicotine-dependent group and were not found in our population of healthy individuals. But putting this all together, How do all of these pieces make sense? Because first we talked about things in a group average way. First, showing that on average, those who use nicotine spend more time in their frontal insular default mode network, which, as we talked about, makes sense. It makes sense in terms of all of the data we've been talking about earlier in this task, because greater interaction between our default mode network and salience network is linked with substance use, cue-induced craving, withdrawal, so on and so forth. We also know from other studies that greater time spent in the frontoinsular default mode network is associated with more rumination in those with major depressive disorder. So collectively, this is suggesting that spending more time in this frontoinsular default mode network is linked with spending more time thinking about internal states, whether it's rumination on negative affect having to do with major depression, or focused on greater cue-induced craving or withdrawal states, but anything that's going to drive your attention internally, both from looking at substance use and mental health issues. Things become a little bit more complicated, though, when we consider other factors of mental health, because what we showed was that less time in this frontoinsular default mode network is linked with more trauma-related alexithymia, meaning that what we see on a group level is not really exactly lining up with maybe what we would expect when we start to consider these other risk factors. Because the easy thing to think is that all risk factors should go together. And that's not something that we typically see, or I typically think is how things work. I think when we start taking into account different risk factors, we start to see a little bit more nuance. And that's something that fits with a hypothesis put forth by Marty Teicher at McLean Hospital, who has said that if you look at a group of individuals with the same psychiatric diagnosis and you split them up based on childhood maltreatment, they're neurobiologically different, suggesting that you can have different neurobiological paths to the same psychiatric issue, whether that's a mental health condition like major depression or if it is a substance use disorder. You can have different neurobiological paths that lead there. Some are driven potentially by childhood maltreatment. Some might be driven by other things. We also know from the work by others that reduced communication between the default mode network and salience network mediates the relationship between alexithymia and tobacco craving. So we're starting to see more evidence that if we start to consider other risk factors, other sources of variance, our story that we know to be true on average starts to become more and more complicated. And this is part of what I think is playing a role in why it is so difficult to come up with a one-size-fits-all treatment, because I don't think we can do that without considering all of these other different factors. And collectively, when we're talking about this data here, what I think might be going on is that there's potentially an optimal amount of time to spend in the frontoinsular default mode network in order to process emotion regulation, whereas too little time is associated with alexithymia, too much associated with rumination or preoccupation, and it doesn't matter which flavor of emotion dysregulation you have, both can be related to continued nicotine use. And so this is just one example of how including transdiagnostic factors of mental health can kind of change our view on the neurobiology of nicotine dependence. But we also know that for the most part, when we're talking about mental health issues, we're talking about categorical definitions. People either do or do not have something like schizophrenia and nicotine and major depression. And we know that the rates of nicotine use are very high in these populations. And the question then is, well, why? What explains the high level of use? And is it necessarily the same across different mental health issues? And is it the same for those who are healthy? And just to give a brief example of how we've been looking at this, we've done some work with Dr. Lauren Moran, looking at nicotine use and schizophrenia. And one of the first things we did with her was we looked at brain activation to smoking cues. And in our healthy group of individuals, we found what we had expected. Here I'm showing you it in a bar graph, but here what we're seeing is that healthy individuals have more activation for smoking cues relative to neutral cues. Not unexpected based on everything that we talked about earlier. What's interesting, though, is when we look at a group of people with schizophrenia, we do not see that same induction of brain activation for those smoking cues. Again, this kind of has that feeling of, wait a minute, these risk factors are not going together. People with schizophrenia are more at risk for using nicotine. Shouldn't they also have this higher Q reactivity? But maybe there's other things driving continued use in these populations that's not always necessarily the same. And one of the big kind of things in the literature for schizophrenia is this idea that nicotine could potentially be mitigating a cognitive disruption. And so Lauren Moran did another study looking at behavioral responding during the stop signal task. And what I've plotted here is the post-error slowing reaction time. And you can see that folks with schizophrenia have reduced post-error slowing, meaning they're not slowing down enough to process and update the fact that they made an error under placebo. What happens under nicotine is you see that the folks with schizophrenia, now their post-error slowing looks pretty comparable to our control group under placebo. Really kind of fitting with this story that nicotine appears to normalize cognitive disruptions in those with schizophrenia. And also supports this idea that the drivers of substance use may differ in those with a mental health issue. We see somewhat similar stories when we're looking at major depression. Here we've looked at reward processing because we know that's disrupted in both nicotine dependence and major depression. What I'm plotting here is behavioral reward reactivity on a probabilistic reward task. The higher the bar, the more reward reactive the group is. And what you can see is that our healthy controls are more reward reactive than folks with a history of major depression. And this is true if you're not a smoker. If you are a smoker, our groups now look the same. And it's not because our control group had any sort of difference in the reward responding, but our folks with a history of major depression did. We see this normalization of reward sensitivity. And this fits with a story done by my collaborator, Dr. Diego Pizzagalli, where they use the same exact probabilistic reward task in humans and in rodents. And what you can see when you take nicotine away is that following smoking, which is in the lighter blue bar, you have high reward responding relative to when nicotine is gone under 24 hours of abstinence in the darker blue bar, fitting with what we think we know is going on during nicotine dependence, that you have this reward dampening effect, you have this anhedonia. But what's really interesting is what happens when you look at the humans who do or do not have a history of depression. And I want to draw your attention off into this third block of the task. Because when we look at the folks with no history of depression, well, the reward responding for whether they're currently smoking or if they're following 24 hours of abstinence looks exactly the same. Not so much when we're looking at folks with a history of depression. So one thing that could plausibly be going on when we're considering folks with a mental health condition is that they're not only experiencing a withdrawal effect on things like reward functioning, but they're also having a concurrent unmasking of a deficit that was potentially there to begin with. And that unmasking is something that might lead to these higher levels of withdrawal and more difficulties in maintaining abstinence. And it also kind of begs this question of whether nicotine is fixing something in those with major depression, which is part of the self-medication hypothesis that has been discussed for some time. But it's something that we wanted to dig into more directly because we wanted to determine whether nicotine can have a direct impact on brain circuitry of those with and without major depression. This work was done in folks who do not smoke. So these are non-nicotine exposed, non-nicotine using individuals. And what we really wanted to know was whether an acute dose of nicotine impacts the connectivity at rest between the nucleus accumbens and the rostral anterior cingulate cortex. Because as we've talked about throughout the symposium, those two nodes of the reward pathway are part of the reward pathway. And we know that disruptions between them have been linked to things like major depression. And that's what I'm plotting here. I'm plotting the connectivity strength between these two parts of the brain. I'm plotting R values. And the higher the bar, the more functionally connected those regions are. And under placebo, what you can see is that our healthy controls have more functional connectivity between these regions than do our folks with a current diagnosis of major depression. But these folks underwent a randomized double-blind placebo-controlled study where they also got a 2 milligram dose of nicotine. And once again, you see this story of nicotine seems to have this normalization effect in those with major depression, whereas there's no real effect in those who are nicotine dependent. Really kind of fitting with this idea that nicotine might be normalizing our reward circuit. And this suggests that this is potentially a mechanism for nicotine's impact on measures of reward sensitivity, supporting this idea that, well, maybe this idea of the self-medication hypothesis is true in some aspects, at least when we're talking about this one brain circuit and during early nicotine exposure. I also have to admit, I'm not quite sure how I feel about the term of self-medication. I think of it more as people are different in terms of how their brain is functioning and organized, and that individual variance of where you start can place you more at risk for continuing use or not. And it's plausible that it's not necessarily this reward enhancement effect, but it's the delta, right? So if you're starting at a lower kind of set point for your reward reactivity and nicotine brings it up higher because there's a larger amount of place to go, then that is something that is going to be potentially more salient to the individual, which will potentially go and continue use longer term. Same sort of thing when it comes to looking at schizophrenia. Those who have this initial deficit, who experience a benefit from the drug in some way, will continue potentially using it over somebody else. This all fits with the idea that different populations can have dissociable responses to nicotine that drive continued use. This isn't really saying that nicotine has different effects in different people, but the effects of nicotine might be more apparent because of what I said before, because different people are starting at a different point. So that delta, that change that is induced by nicotine might be more motivational, might be more salient to certain individuals. And so to wrap everything up, what we've talked about is this idea that the default mode network and salience network play an important role in nicotine dependence, because we know that these networks commonly react to smoking stimuli, and that the activation of parts of these networks is associated with treatment outcome. And targeting parts of these networks also has an impact on treatment outcome. We know that at rest, stronger connectivity between the default mode network and salience network relates to greater craving, both in the laboratory and smoking cessation outcome treatment. So what we're saying here too is it's not necessarily just how your brain is responding to cues in their environment, but how your brain is functionally organized that can place one at risk for how that brain is going to react under certain conditions, and then put one at risk for behaving or having an emotional response that can kind of lead to continued use. And we've also talked about how newer methods of resting state temporal dynamics are also important, because this is giving us more information about how the brain is functionally working at rest. And we know that we can impact these dynamic states pharmacologically. And this also, again, is just another piece of the puzzle, indicating that nicotine-dependent individuals spend more time in this fronto-insular default mode network state. But with all of that, with all of our discussion about data on average, we've also talked about how mental health should be considered to better understand the neurobiology of substance use. Because when we started to consider those things, our story became a little bit more complicated. Our group average data might not be true when we consider these other points of variance, because it really might be that we need to take into account who is key reactive, who is gaining a reward benefit from nicotine, who's gaining a cognitive benefit from nicotine, who's gaining some other benefit from nicotine or an opiate or a stimulant, to really understand what is maintaining that long term, to come up with a treatment to do what Colleen said during the panel, which is meet people where they are. And I think that's what we really need to do if we're going to move away from this idea of having a one-size-fits-all treatment and instead really address the underlying need. So with that, I would just like to thank you all for your attention and for the invitation to be here, and thank everyone who's been involved in this work, as well as the funding over the years.
Thank you. Great talk. I don't know if you have any questions. You can approach the microphones. It can be in Spanish. I can translate, no worries. Okay, we have one question.
Yes, I have a question. Well, beautiful talk. You were talking about how nicotine may influence the reward sensitivity of its users. Have you, apart from doing neuroimaging studies, tried to use questionnaires? For example, I used the PAS, the Physical Anhedonia Scale, and and it measures the reward sensitivity of people, right?
Yeah, no, absolutely. That's a really great question because that's something that you could much more easily do. We've used the SHAPS, which is another questionnaire that targets anhedonia. And in the context of this study, showed that it was those who at baseline had the highest levels of anhedonia who had the largest impact of nicotine. So I think there are ways to start pulling those questionnaires in as well.
Thank you. Another question.
Thank you, Amy, for such an interesting talk and for raising our views on this very important aspect of substance use disorders, because these problems, the problematic use of substances frequently comes with comorbidities, right? Such as depression, as you rightly said. And meeting the patients and these individuals in the state where they are is relevant for the outcome, no? For the therapeutic outcome. So I wanted to ask, how is this approach of manipulating these structures from the salience network or from the default mode network is outside nicotine? Because I've seen after the work of your group or also Bernard Lefol or also Abraham Sanjan group, we have this possibility to use procedures like TMS for tobacco, right?
Yeah.
But what happens with other substances? Because the effects of different substances leads to different kinds of reward and different kinds of abstinence. So what happens, for example, in the case of alcohol?
Yeah, let me see if I can answer your question in a very roundabout kind of way. Getting at the idea of different substances and potentially using them together, we know that using nicotine can lock in other substance use disorders as well. Like if you're using nicotine, it's harder to quit using cannabis. It is more likely that you're going to have more opiate-related craving and use. So there's something to what you said in terms of using different drugs is going to potentially impact the disorder and what we're looking at. But when we're thinking about these networks and what they're doing, right, they're large scale networks. They're not specific to anything having to do with nicotine dependence or alcohol or major depression. And there's the theory that these large scale networks are dysfunctional across mental health issues. And so as we were talking about in the study of childhood maltreatment and alexithymia, spending time in that frontal insular default mode network more is not only linked with nicotine dependence, but rumination and major depression. And I expect it to be the same with other things as well, focused on those internal states, the craving and the withdrawal element of whether it is alcohol use disorder or nicotine dependence or opiates. It's underlying that fundamental risk for these continued drugs. I don't know specifically about alcohol use disorder. I know with nicotine, it tends to drive up the salience for not only nicotine, but other drugs of abuse as well. So I think some of these things might be a little bit heightened for nicotine dependence, but I don't necessarily think that they're untrue for other substance use disorders as well. I'm not sure if that.
Yeah. That was the whole point. Thank you very much for sharing your thought, and especially for pushing the field forward. Thank you.
Thank you.
Okay, is there another question? Otherwise, I have a question. So I'll take the opportunity to ask a question. I'm interested in that the self-medication part, which we call it self-medication, but it might not be. So we published one paper with borderline disorder, personality disorder patients that use cocaine, and when we saw the results were that these patients that had the dual pathology actually, in some of their measurements, including frontostriatal amygdala connectivity, pretty much went into the almost control levels. So I was wondering if you have a thought about why certain conditions have certain drugs of use, because, I mean, stimulant is a stimulant, but maybe every stimulant has a different effect. So why do some pathologists or people with some pathologies prefer one over the other? I don't know if you have seen that in nicotine, for example.
Yeah, I mean, I think going back to talking about schizophrenia and major depression, they're exhibiting different deficits that the drug is then kind of mitigating. And the same sort of thing might be true when you're thinking about the data that you have, that the mental health issue is placing their brain to function in a certain way that for them, a stimulant is having an effect that leads them to now look more like a healthy individual. So it could be that even if somebody didn't have a disorder, but say their brain was less efficient at processing rewards, nicotine would still have a facilitatory response. So it's about where they start can impact how the drug looks like it's maybe having an impact.
Right. Okay. Thank you. So if there are not more questions, I want to thank you again for coming and appreciate the effort. Thank you.
Thank you.